We might have sort of gone over this too quickly. This plan is budget neutral. This plan does not require an additional dime in taxpayer investment to cover 100% of the American people. It's absolutely essential on our part that we create a healthcare reform model that doesn't rely on more money going into the system. We've got to make sure that the architecture of what we design is sustainable for not just the increase in the population, but the ebb and flow that we're going to find through breakthroughs in technology and healthcare in the future.
Let me make one point on sustainability, because it's a question you have to ask no matter whose plan's out there. If you take everybody and just put them in an insurance plan, with insurance rising at 7.2% per year, are we sustainable? No. If you have a government-run plan and you allow the prices to rise at 7.2%, is it sustainable? No. We are not competitive globally. So you have to have a plan that looks at the sustainability of it in an area where we can afford. Healthcare inflation should not be as high as underlying inflation. If anything, it should be less because of efficiencies and technologies. What we have is a third of the money that's being spent in healthcare not going to help anybody get well and not preventing anybody from getting sick.
Senator, could one of the senators comment on where this fits in terms of the bipartisan track that at least is being attempted in the Senate with Senators Grassley and Davis?
Sure.
Sure. It's absolutely consistent with it. I mean, we're all working toward a similar goal, which is to change health care this year and to make sure everyone can afford health insurance. The advantage of the Burr-Coburn proposal in the Senate, along with that of the members of the House, is it injects powerful, different ideas into the debate. So we'll be having, for example, there's a breakfast tomorrow morning with about 22 bipartisan members of the Senate who will be considering different ideas and hearing from Peter Orszag, who's expressed concern in his writing about the Medicaid program's effect on states that Tom and Richard have talked about. So this puts Republican ideas into the middle of the fight in the debate about how do we do the best job for individuals, and we hope Democrats are impressed by the power of the ideas.
Also on policy, are there any government federal mandates as a part of this plan?
One is there is a minimal basic plan, which is the lowest FEHBB plan. That's the only mandate in the whole.
Everybody is required.
If you offer a plan, we leave most of this to states. In other words, we really believe in the 10th Amendment, and we really believe there are 50 different areas out there where they could experiment. But what we do is we set it up to allow states. We don't mandate that any state has to do any of this, but they're all going to want to do something, and what we're going to do is create the freedom for them to do what is best for their state. Look how many states are struggling trying to get through CMS to get a program to fix their Medicaid. I mean, it's ridiculous. They got to come ask Washington so they can do what's smart for their states. So what we've done is we've said, here's ideas, here's incentives. If you fix tort reform, here's some more money. We don't tell you how you have to fix tort reform. We just say if you'll fix tort reform in your state, where you take some of the $200 billion we're spending a year on tests that nobody needs, and you'll change that, we'll give you more money in terms of your Medicaid block grant or Medicaid assessment, the $5,000 per family that'll come along with the $5,700 tax credit per family. So the only mandate is we don't want anybody to be without basic coverage, but we also allow this to be able to go around the states that have 180 mandates that cause people to pay for something they're never going to use.
We also learned from Part D Medicare that when the American people are offered a choice, not everybody can choose. So we do allow states in those instances where somebody gets a tax credit, chooses not to opt into coverage, those states can auto-enroll them into a catastrophic policy. At the end of the day, we want to make sure that we can say to the healthcare delivery system, everybody has the means or the coverage to take care of their healthcare needs. Our attempt, again, is to reinforce the fact that we don't want to deliver primary care in the emergency room. We want to deliver primary care at a medical home.
Senator Coburn?
Yes.
If I can ask a question on another subject.
Outside of health care?
Outside of health.
Well, we'll take that question afterwards. Let's stay on health care here for a second.
Let me make one point to the question you asked. This is not a conservative plan. It's not a moderate plan, but I believe it's a credible plan. This plan provides universal access, it's zero cost, and it solves the unfunded liability of Medicaid. It does those three important things. And I would challenge, as this debate heats up next month in Washington, that when people lay out their plans, if they meet those three criteria.
Let me just,
sure.
okay, I'll just add to your, because you asked a big question. Mandates and things like that, universal coverage. Rather than having a federal mandate that everybody must buy health insurance, we believe giving the states the tools and the incentives to have auto enrollment will get us to that goal without mandating it on people. The state exchanges, which states have the freedom to set up, different options on how to make sure people with pre-existing conditions get health care, will have as one of their requirements the standard Blue Cross Blue Shield standard option that we in Congress have as one of the available benefits for people to choose from if they choose to get their health insurance through a state exchange.
The insurance industry has argued, though, that they need that mandate to do pre-existing conditions. Do you just disagree with that argument?
You know, we have the incentives to change insurance to truly being insurance. Right now, insurance is prepaid medical expense. You pay them money, somebody pays them money for you, they pay your bills. We're never going to get out of our hole until we manage chronic disease. And so what we do is we disincentivize cherry picking in this bill. It becomes painful for an insurance company to not cover somebody who has a chronic disease because they're going to pay for it anyway, if in fact the state utilizes this exchange method. It's called risk readjustment. Now, none of the insurance companies want us to tell them how to run their business. We don't want to tell them how to run the business. But what we recognize as a national priority, unless we're going to incentivize wellness, unless we're going to incentivize prevention, unless we're going to incentivize the management of chronic disease, we aren't going to be able to afford any health care, whether the government runs it or it's in the private sector. So we want to set up the competition so that by managing chronic disease, an insurance company actually makes more than ducking the patient with the chronic disease. And that's what we've done.
Won't that take time to
Yeah, everything takes time. Setting up a government plan and then showing how incompetent it's going to be is going to take time too.
Gentlemen, quick question about the tax incentives. A large portion of this country has employer-based coverage that's substantially more, costs substantially more than, I think, $5,900. Is that what the tax credit?
5,700 is the credit, and that credit can be used to access health care or to pay the tax consequences that might exist from now making the health benefits supplied by an employer taxable in income. Well, it doesn't take a very tough mathematical calculation to say that $5,700 covers the tax consequences of an employer-provided portion of health care benefit up to close to $17,000. That's well above the federal government's level of participation for federal employees.
So your contention is that for virtually no Americans will have to pay more for their health insurance?
That's
Right.
exactly
Most people
right.
get a net tax cut.
And the benefit is that for those of us that are federal employees where the federal government share is $11,000 to $12,000, we've got money left over that goes in a prevention account, and that prevention account can be used for anything that's not paid preventative or by the insurer, or to cover eye care or dental care, which we do see as an important preventative piece of health care. The first time we've expanded one coverage to do all of them.